Welcome everyone to Module 4 of our Trustee Training Program, which focuses on managed care. Managed care is a term we hear frequently in the context of medical schemes. It sits at the intersection of cost control, quality of care, and responsible benefit management. Yet for many trustees, it can seem technical. Today's session is designed to unpack what managed care really means, and more importantly, what trustees need to understand about it in order to fulfill their governance responsibilities. Guiding us through this topic will be Irene Zambellis, who's a highly experienced trainer. Many of you will know her from previous trustee training sessions. Irene has extensive experience in the healthcare funding environment and brings a practical perspective to how managed care operates within medical schemes. Irene, welcome, and thank you so much for joining us today.
Heidi, thank you so much for this invitation. It's always a pleasure, and I'm looking forward to our discussion. I am going to be putting my camera off, if that's okay.
To save bandwidth, I think it's a good idea. And when Irene is speaking, I will put my camera off. So let's go on to the agenda, Irene. And let me briefly walk us through what Irene will cover in today's session. We'll begin with some foundational concepts, including what we mean by health, especially in the context of the wellness continuum. From there, the presentation will move into the risk management process, which is central to how medical schemes operate. We'll then explore what managed care actually means, followed by how managed care contracting works in practice. We'll also look at the standards that govern managed care and finally discuss an important question for trustees, which is how we measure whether managed care interventions actually deliver a return on investment. By the end of the session, trustees should have a clearer understanding of how managed care supports the sustainability of medical schemes while ensuring members receive appropriate and quality care. Irene, take us through what health is in the context of the wellness continuum.
Sure, Heidi. I think because managed care is about health risk management, understanding health is an important starting point. And the way the World Health Organization actually defines health as a state of complete physical, mental, and social well-being, and it has to include all three of those components. And it's not just merely the absence of disease. When we look at the wellness continuum, and you can see here it goes from the right side being a high level of wellness to the left is premature death. But let's see what leads to a high level of wellness is being aware of your health and the health risks that you may face. That one then gets education, information about your potential health risks, and you're able to change your behaviors so that you can achieve a high level of wellness. So not only is this of benefit to us as individuals, but to the scheme, because this is where the scheme incurs the least cost. And this is why we say schemes should focus benefits on primary health care and preventive care. The opposite is true when we go to the left side of the continuum, which often we say as people age, we get predisposed to more conditions. The way we manage our health is an important factor as to how quickly we may get sick, often. So we can get signs and symptoms, which is evidence of disease, and as that disease progresses, it impacts our ability to complete our activities of daily living, and which really relates to self-care. That can result in premature death. This is what we call the treatment paradigm, and that is where it becomes more expensive for medical schemes to treat. That is what is so important for trustees to understand, that the way they design their benefits can influence the wellness of their beneficiaries.
Thank you, Irene. Another term that we hear so often in the context of managed care is value-based healthcare. Can you explain briefly what is meant by value-based healthcare?
And we can start with a definition, Heidi, and it is a term that the Council for Medical Schemes has also used in saying that the schemes must now start focusing more on value-based healthcare. And what value-based healthcare means is it's a framework that focuses on increasing the value of health services. And what that means is, if someone gets a health service, be it a consultation, an investigation, a treatment, that it's got to add value in making that person live longer, have a better quality of life. That is patient outcomes. And one needs to look at it relative to the cost. So you want to have the least cost for maximum patient outcomes. And what that includes is that in the benefit design, there should be preventive care, like for vaccines, immunization, flu vaccines as we come to winter. That helps prevent disease. But not only that, screening goes hand in hand with preventive care. And what screening does for high-risk individuals is allow for the early diagnosis of a condition. The earlier you diagnose a condition, the easier it is more effectively treated, and one has a better prognosis. And coupled with that the health services provided are appropriate for the condition and the severity of it. And this is where trustees may start saying, we're not medical people, and we'll address some of that as well as we go on. You're not expected to be medical people, but one is expected to have that understanding of the benefits. Benefits also include supportive treatment. So what is the benefit of physiotherapy and occupational therapy? And lastly, it's the end-of-life care. And with end-of-life care, there have been a lot of reports, and trustees can ask for reports. What has a patient's health journey been in the last 6 months prior to death? And what you'll find is that they can be very expensive end-of-life journey that they have traveled, and sometimes it is unnecessarily so. And that is something that one needs to be able to focus on, and to make sure that people achieve the best health outcomes in the most cost-effective manner. And that does not mean, Heidi, denying people care. There's a difference to that.
Thanks, Irene. This following slide illustrates a really important reality for schemes, because benefit design alone can't fully manage healthcare risk, especially when it comes to costs, because schemes are required to cover PMBs, and the PMBs limit the ability of schemes to manage costs purely through benefit restrictions. And I suppose that's where managed care becomes critical. Can you a little bit?
Sure, Heidi. And I think based on our previous discussion on preventive care and focusing on what benefits one can provide to get people to achieve the highest level of wellness is something we must keep in mind. So when we look at the scheme's benefit design, this is where health risk management actually begins. We know we have two groups of benefits, the prescribed minimum benefit group and non-prescribed minimum benefits. With the non-prescribed minimum benefits, trustees have the ability to manage certain of the health expenses using benefit design, like your scheme exclusions. You can set a scheme tariff, because we know private providers have no regulator tariff. You can impose annual limits, saying there's a financial cap on what one can spend in a particular category for the year. Or you can ask the members to share in the cost, making them aware of the expenses. You can have waiting periods in place for new applicants and a savings account. All of this helps shift some of the responsibility for the spend onto the member. When it comes to the prescribed minimum benefits, Regulation 8 of the Act says any option must pay in full, not limited to the scheme tariff, without co-payments or deductibles for the diagnosis, treatment and care costs of PMBs. Now, we know this isn't an open checkbook. It can be limited, and that's where managed care comes into play, where you can limit it to what is PMB level of care. And managed care can play a role not only for PMBs, also for non-PMBs. And it's important because what managed care does is say this is an appropriate service for your condition and your severity. And that is an important component of managing the affordability of the scheme.
Irene, another important concept in managed care is managing risk management. And I mean, we all know medical schemes don't treat patients. They make funding decisions. And so health risks arise from several sources, including, for instance, the number of beneficiaries requiring care, the quality and cost of services, and issues like fraud, waste, and abuse. Could you give us a little bit of an explanation of what fraud, waste, and abuse actually mean and the difference between them?
Sure, Heidi, and I think this is an important point, because the primary goal of health risk management or managed care is to get rid of wastage out of the system without compromising the quality of care. And that's where managed care comes in. You're managing the healthcare funding. So in the medical scheme environment, we know there is fraud. And fraud, they've estimated, can be anything between 5 to 15% of the healthcare expenses, which is, it's a substantial amount of money. Managed care can play a role what fraud is and what makes it different to abuse and waste is that fraud is done with intent for self-enrichment. So a provider may submit a claim for services never rendered, or a unregistered beneficiary can use a registered person's details. There are many examples of fraud that we can bring, but that is done with intent, and it's actually a criminal matter. Abuse is a little bit different and more difficult to prove, in that abuse says that the provider is billing for things that do not follow best medical practice guidelines. And this is an important factor, that schemes must have best practice guidelines that they've sourced from providers, and we find that the provider hasn't stuck to the guideline. When we look at waste, it is really the unnecessary, careless use of service. We get many unnecessary hospital admissions, as an example. So if you have proper managed care programs in place, this over-servicing can be limited, and fraud should be easily detected, so that at the end of the day, one can decrease the number of the claims, you can decrease the cost of the claims to what is medically necessary, and improve the quality of care. That is the aim of the program.
Thanks, Irene. So the process of risk management is really, really important. Can you take us through how a scheme would look at this and why it's so necessary?
It is, Heidi, because there's a cost to manage care. And you need to be able to show that as a board of trustees, you've applied your mind in the spend. So when we look at any risk management process, there are certain specific steps that must be followed to show you've applied your mind. And the first one is that you are able to identify the risks of your beneficiaries. We call your beneficiaries your risk pool. Each of your beneficiaries have a certain age, a certain burden of disease. You need to understand, because that is the risks they bring, the health risks. You will find that you will be provided with reports that can list what are the top 10 or 20 conditions of your beneficiaries. And that is a very important starting point. The second starting point that you need to have is that you are able to analyze those risks and prioritize them according to cost. So what is that? Which of those conditions have the biggest financial impact on your scheme? Because now you are armed with the information that you can find what is the best managed care program for your risks. And schemes' risk profiles differ. So you need to be bespoke. Once you've examined the potential programs that would address your needs, that you can then implement the right one. And then what you've got to do is continually monitor and review. Is it is that solution still pertinent for your risks? Because we know risks change, and you've got to continually evaluate, and you've got to measure the return on your investment, because these programs cost money. What is the cost savings that you have achieved? And what have you achieved in improving the health of your membership? In being able to do this, you need very good data. And this data includes clinical coding, which is important, and to be able to analyze it. And that is what is so important about risk management.
It is important. The other important thing and the cornerstone of medical scheme governance is the Medical Schemes Act. And the Medical Schemes Act contains quite a lot about managed care. I wonder if you could take us through the relevant section that trustees are aware of what it contains.
Heidi, you're so right. It's so important. And I've always encouraged trustees to read the relevant sections of the law. And when you do it by section, it's far more understandable. The relevant section for managed care is Chapter 5 of the regulations, Section 15 in its entirety. And what this does, it starts off by defining managed care. And if you think of those steps I've just mentioned that are part of the risk management process, you will see them coming forward in this definition. So let's do it bit by bit. The definition starts by saying managed care means clinical and financial risk assessment. So clinical is identify your risks and prioritize them so you understand the financial impact. Now that you know your risks, it includes management of healthcare. So you, as a trustee, need to manage the risk of your scheme. That is one of your fiduciary duties. And health risk is part of it. So you need to show you've applied your mind to that. And it says so that you can facilitate what's appropriate and cost-effective health services within the constraints of what's affordable. So some lower cost schemes may fund less expensive treatments, and that you have rules and clinical-based programs in place to help you achieve this goal. Now, just for clarity's sake, Heidi, a rules-based program is something you've put into your scheme rules to cut back on cost. And your clinical management-based programs is something a bit different, because what that is, it matches the individual's health risk with what is the appropriate treatment for them. And let me give you an example. A rules-based program, most schemes have this one in place in their rules. No admission to hospital for routine dental care will be authorized. You must have the treatment in the dentist chair, avoiding the hospital event. Now, that is good medical practice, because you don't want people to have unnecessary anesthetics, but also the scheme doesn't want to incur the cost of the hospital if they can avoid it. So it must always be where you're not compromising quality of care. And that is something that we've got to understand. That is a lot cheaper to achieve if you've put it in the scheme rules. And maybe people can think of other things that they've got in their rules that will help ration healthcare without compromising quality of care. And you've got to say to yourself, can I reduce the cost without impacting the health of the individual? And that's what makes it managing health as opposed to just cutting cost. If
Such
we
an
look,
important slide that about rationing. Sorry, I interrupted. Carry on, Irene.
no, that's an important point, Heidi, because people are not comfortable with the term rationing healthcare. It just doesn't sit well with a lot of people. So we need to ration it rationally. And that is an important thing. We don't want people to have loss of life or suffer complications unnecessarily because one has denied funding. That isn't the point of this exercise, which is why medical professionals are employed in managed care organizations to help make these funding decisions. And one has to use best medical practice when setting guidelines. And that's a very important foundation, which comes to this section of Regulation 15. And we can see here in Regulation 15, they talk about the standards for managed healthcare. That we don't just cut costs, that you are transparent as a scheme, you put protocols in place, which is a treatment plan, but you make it transparent, which is important. It's not a scheme's cookbook. You can show that you've sourced it from the medical fraternity and that you've applied clinical criteria and you've done it consistently. What you do for one, you do for all with the same condition. So it's about being fair. So schemes can become more affordable. You want to get rid of the wastage out of the system, and that's what's important. What is also important though, Heidi, because the scheme has the contract with its beneficiaries, the scheme cannot abdicate its responsibility to its members just because they have a contract with a managed care organization. That responsibility to the members will always be by the scheme. So that is also something that comes through pretty strongly in the regulations. When we look, Heidi, I don't know if you hear this, but we get this question often. Well, a scheme is trying to treat a patient. I don't know if that is something you've heard about.
Yes, all the time.
I used to get this, Heidi. I was always told I didn't see you in medical school, and yet you're trying to tell me how to treat my patient because I was on the funding side. So medical schemes are funders. They are not treating healthcare professionals or doctors. And there's a difference. But what schemes need to do is take from the medical fraternity what is best practice. And they need to show that they've done that. And they then use that to limit benefits accordingly. So what one wants to do is to limit the benefits to what is medically necessary, so that the right principle can apply. You have the right patient with the right condition and severity of condition, getting the right treatment by the right provider. We have a lot of work done by specialists that could be done by GPs. As an example, I'm not saying all, but we must ask the question, at the right place, can the treatment be done out of hospital instead of in hospital? Does the patient need an ICU bed, or does it need a general ward bed? At the right cost. The scheme can negotiate a preferential tariff with a group of providers, and that things happen at the right time. So never at the cost of compromising quality of care.
Sure, so important that. And then in terms of contracting for managed care services, what is required by the trustees in this regard?
It's an important question, Heidi, because Section 15 gives some detail in this regard. And the one thing we must remember here is that managed care companies are for-profit entities. What Regulation 15B says that managed care companies must get accreditation with the Council for Medical Schemes to be able to provide managed care services to a medical scheme. So they're regulated by the Council for Medical Schemes. They need to have a valid accreditation certificate. The accreditation is given for a period of time. It can be suspended or withdrawn if they do not have the necessary infrastructure and skill to provide the service, which is important. In addition, though, to having that level of accreditation from council, the scheme must enter into a contract with a managed care organization. This contract is very important because it needs to itemize what the services are that will be provided and at what cost is the scheme going to pay for those services, and how will they measure the effectiveness of the program. It's important that one goes into that detail. You cannot assume that because a managed care organization has a CMS accreditation, that this is the right program for your scheme. Accreditation doesn't relieve the trustees of their fiduciary responsibility to make sure that this program meets the needs of your scheme. And those trustees must apply due care and diligence when they make that decision. It is important. What the council has also done is given a guideline for the preparation of managed care agreements in compliance with the regulation. and accreditation standards. So they have given this particular guideline was published in September 2022. And what it says, that schemes must apply their minds, that whatever managed care program they get, it must be in the interests of beneficiaries. And there must be regular reporting on the performance. It's not always that easy to measure the return on investment. And there has to be a genuine transfer of risk from the scheme to the provider. Remember, the scheme takes all the risk. The provider submits a claim, the scheme, if it's in line with the rules, pays. So is there a genuine transfer of risk to the providers? And are you protecting client confidentiality? This is in the Act, Medical Schemes Act and Regulations, not just with the Protection of Personal Information Act. So there's a lot that goes into your choice of managed healthcare services.
Thanks, Irene. Could you take us through then what are typically what are the managed care services that schemes would choose?
And I think, Heidi, just to make the trustees also aware that also published in September 2022, the CMS published an updated, accredited, managed healthcare healthcare services, standardized classifications and naming conventions. That's a bit of a mouthful. But if we look at the categories of managed care services, it starts off with hospital benefit management. We all know that it's about 36 or 37% of healthcare expenditure goes to hospitals, which we know it's the most expensive. There are different types of hospital benefit management services. You can see their pre-authorization, case management, and clinical audits that fall under that. Then there's pharmacy benefit management. And we can see here also for drugs, pre-authorization services, drug utilization review, disease risk management support services that some pharmacy benefit management companies also provide. And then there's active disease risk management services. And just to note, the attention or the problem always sits, the devil sits in the detail. There is a difference between disease risk management support services and active disease risk management services that one needs to be aware of. The fourth one here, Heidi, is a very important one, and I feel where we really need to put even more attention, and that is the network management services. And the future of managed care really rests on restricting choice of provider for the members. It's not something the members enjoy, but the scheme can become so much more efficient in their delivery of services and be able to enjoy cost savings if they manage networks well. And that's the thing, manage them well. Then there's dental benefit management services, active disease risk management support services, and healthcare services, managed care risk management. So it's just being able to look at the different services the way that they are listed in this guideline and the way they've been categorized. What is important here is that you are able to report to council saying, this is the service we've got. This is the value we got from the service. And that's where this categorization really helps, that we're comparing apples with apples, that we're not mixing the active and the support and whatever together, which is important. And that's where the council is putting more attention that one can look at.
Thanks, Irene. But of course, managed care relies on a number of sort of practical tools and programs. Can you give us some examples of the different rules and sort of clinical management-based programs? And maybe talk about the importance of evidence-based medicine in all of this.
And I think, Heidi, when we're talking about evidence-based medicine, it's important because what Regulation 15 says, that no matter what your managed care program is, and here I've just listed the ones we're familiar with, whatever restrictions you place on funding, remember the patient can go to the provider and get whatever treatment they decide. The scheme doesn't get involved in that. The scheme gets involved in what will they fund of those services the patient received. And the scheme must, for each condition, and this is a big task, make a basket of services that they will fund available if it's something they've included in their scheme rules, by liaising with the medical fraternity. So what the regulations say, and they've defined it, that when a scheme restricts services for a condition, according to severity as well, they've got to use evidence-based medicine. And that is a big word. What it actually means, that a scheme needs to look at what is the current research says. So this is two important words. The word current, so the scheme needs to be up to date. And if you think of all new technologies and drugs that come onto the market for treating certain conditions, a scheme needs to decide, well, are we funding this? And if we do fund it, what's the cost impact for all our members? So you need to look at what's current and what the medical research says. And you need to show as a scheme that you've taken that into consideration. So if anybody asks you, what is the research you used to come to this decision, the scheme needs to make it available, either to the regulator, to the public, or to the beneficiary. But it's not just limited to this, because we know current best evidence is what schemes use to put their protocols in place, which is a treatment plan. However, we know that certain patients may be the exception, and that's why schemes need to allow for a motivation from the treating doctor. And this is all written out in the regulations. This is law. So that even though one uses the current best evidence that looks at your treatment plans, and we know formularies are drug lists, what drugs will be paid or won't be paid for certain conditions. But this is where that individual clinical experience of the attending doctor becomes important, because what this means is, should the protocol or formulary not work, cause harm, then the scheme must fund a substitute in full. And that's why it's so important that that doctor can submit a medical motivation. Don't forget, Heidi, you want to cut costs. You want to be more cost effective without compromising quality of care. So should the protocol or formulary not work for me, my doctor can then submit a good, strong medical motivation to the scheme and say, your formulary drug didn't work or made the person sick. The scheme then will fund the substitute, what will work. So one doesn't get, what's the word, that you don't get, not compromised, but not fairly discriminated is the word I was looking for, Heidi, because the formulary or protocol doesn't work.
Yeah, in fairness to both the members of the scheme and as we're going to look at in this slide, and to the healthcare providers who service the patients. And if we can just turn our attention a little bit to reimbursement models. I mean, traditionally, we all know that healthcare providers have been paid through sort of fee-for-service arrangements where each service is billed separately. But can you talk a little bit about the role of managed care away from this fee-for-service environment to maybe more progressive and more efficient reimbursement mechanisms that will encourage more efficiency and also uphold the quality of care?
And I think, Heidi, you're so right there. What we've discussed up to now really focuses on decreasing the number of claims without compromising the quality of the claim. But it doesn't really impact the cost of the claim, especially because there is no regulated tariff for private providers in South Africa. And what that means, private providers can charge what they would like. There's no ceiling to it. And if it is a PMB condition, then they must pay that claim as a scheme in full. In light of that, this is where network management works, where a scheme can negotiate with providers. And often you negotiate with different networks of providers, be it general practitioner, different specialist networks, and hospital networks. There are many networks. There's also pharmacy networks that one can look at for price, and optometrists, etc. What we call that is looking at alternative reimbursement methods, and that we move away from paying for fee-for-service. So fee-for-service means the provider can bill for every item of service they provide. And the more they bill for, the more money they make. And in what they say, that a fee for service encourages over-servicing. So that's why it is important to move to alternative reimbursement methods. And they can include a fixed fee, where for a day in hospital for a particular procedure, the hospital will pay a fixed amount, irrespective of what the charges were. Like for a tonsillectomy, the scheme will pay the hospital 3,000 odd rand. That's just taken at random, not real figures. So we can see there, you're encouraging that hospital to become more efficient, because their profit margin will be determined by how efficient they are in providing that service. A per diem is a day fee. So for every day in hospital, there will be a fee charged specific to procedures. So for a hip replacement, day one, this hospital will often get a higher fee. Day two will be slightly lower, and day 3, 4 will be lower than day 2. Capitation is a very interesting one, where you get that transfer of risk from the scheme to the provider grouping. In the most, that is where you achieve the best transfer of risk. The group that you have capitated with as a scheme will be paid a fixed amount for that basket of service, irrespective how often the members use the service or not. So the scheme knows for primary health care, this is going to be the expense they will incur. The providers need to manage that risk. Obviously, from a scheme point of view, they've got to monitor how well those providers are managing the health of their members, because you can now move from an over-servicing risk to an under-servicing risk. So there's always a need to make sure that your quality of care is never compromised.
That was really interesting and such an important point to make, and such an important bit of information for trustees to know about, because essentially and ultimately, I suppose, it comes down to sharing the risk for good outcomes with the providers of service. Another term we hear often, and it is to the points that you've just been raising in the last few slides, are EDOs, which are efficiency discounted options. They're very common in medical schemes to improve efficiencies. Can you explain a little bit how they work, Irene?
And I think, Katie, this is such an important development, because what we can see on the slide, we can see with the grey columns is the number of EDO options. From 2017, there were 50, and by 2024, according to Council's annual report, there were 73 in total. They are an option within a scheme. What is important to note with EDOs is the percentage of lives that are not on EDOs. So 64% of the 9.1 million beneficiaries, 64% are not on efficiency discounted options. The idea is we increase the number. We increase the number that are on EDOs. Why? An efficiency discounted option is exactly that. The scheme has negotiated preferential agreements with groups of providers. And that's why I say network management is so important. And this is for groups of providers within an option. Now that's important. Because they were able to negotiate this agreement with the providers, the benefits and the cost savings are shared with the member. So the member then pays a lower contribution for the same option than people that are not part of the EDO. Now, we know that that's not allowed according to the Act, because the Act says all beneficiaries within an option must get the same benefits and pay the same contribution. So people with the schemes with EDOs, they've applied for exemption from council, and they've been successful in that. And that is the efficiency that managed care can provide. And I think that's the advantage trustees should look at and see how they can optimize that for their schemes to become more affordable, but at the same time, not compromising quality of care.
So can we look at the use of managed care options or managed care services rather in 2024, what the Council for Medical Schemes annual report says about that in its latest report?
And I think, Heidi, if we start off with that, schemes paid just over 6 billion rand to managed care organizations in 2024. And I think that number in itself can be meaningless if you don't couple it with how well was that money spent. We know that the money that is spent on managed care comes from the healthcare expenses of a scheme. What is interesting to note, in this graph, they divide the spend between the different managed care programs and between open schemes, which is the lighter column, and restricted schemes. So if we look at open schemes, we can see that they spent 33% on hospital benefit management, then 28% active disease risk management, and number 3 was managed care networks, and then pharmacy benefit management. We can see restricted schemes concentrated the bulk of their spend on networks. Then came hospital benefit management. It is the biggest cost driver in medical schemes. Then came active disease risk management services and pharmacy services. So it's important that we look at the spend and say, what is the return on that investment? It's not always easy to look at it. You need to, in your contract, agree on how you will measure their effectiveness.
Which brings us to the obvious question, right? How do we measure whether managed care programs are effective? And how do we assess the scheme's ROI?
And I think, Heidi, if we think of it, we started off talking about value-based healthcare, and there's this trend of paying for performance with providers. And when trustees look at the metrics for the return on investment, there are 2 important indicators. and we mustn't confuse the two. The one is process indicator, looking at the effectiveness of your program. And the other one is a health outcome indicator. You need both. You need both. The process indicator is going to tell you how many people have registered on the program. And we'll show you some process indicators in our next slide. It's going to tell you how many people had a flu vaccine, how many people had mammograms, etc. It doesn't tell you how many people have controlled diseases, like controlled blood pressure, controlled blood sugars. So when we look at health outcome indicators, the examples are how many people have died, mortality rates, how many people are being readmitted to hospital for the same condition within 30 days of discharge. That is a very important indicator every trustee should be asking for. What is the functional status of the people for whose healthcare is being managed and you're paying for it? That's an important indicator because it shows you how people are able to take care of the activities of daily living, the disability thing, and how many have controlled conditions. For me, this is such an important one, especially like HbA1c for diabetes, because the cost of complications to a scheme, should people not have controlled conditions, is huge. And that is often the problem. The high blood pressure that's uncontrolled can result in a heart attack or a stroke that can go into the hundreds of thousands of rands, like uncontrolled blood sugars for the diabetics. That's what you need to know. So it's a balance between the two, Heidi. And if we have a look here, we can see that Council in their 2024 annual report have been publishing these figures on process indicators for certain conditions. Now remember, these aren't health outcome indicators. And what they show for chronic obstructive pulmonary disease, it's a progressive disease where people's lung function deteriorates, and they're looking at what percentage of people with this condition had a lung function test and a flu vaccine. And can we see it is 28% had a lung function test and 25% had a flu vaccine. Why is it important? It's important because people with compromised lungs, come the flu season, and we're coming up to it now, flu vaccine time in April, are more prone to developing pneumonia, which is so much more costly than having a flu vaccine. And you want ideally these figures to be 100%. So one can say to your disease management company, organization, why are we not achieving higher rates? What are we going to do to improve it? And likewise for people with asthma, we can see their numbers, the percentage, having a lung function test at 8% and flu vaccine at 12% is even worse than the COPD figures. This is my baby for diabetes, because the cost to a scheme, Heidi, of complications, people that are diabetic, this is type 2 diabetes, the complications go into the hundreds of thousands of rands if you can't manage your blood sugars and stabilize them, because of kidney disease and heart disease and amputations of feet and eyesight problems. And the one test that will tell you if the person has actually controlled stabilized their sugars, it's HbA1c. And only 43% of diabetics have had the test. I mean, ideally, I would want a health outcome indicator. I want to know, out of the people that had the test, what was the test? Was it at a normal level, etc.? So that is quite scary. We know that 69% had a kidney blood test, the creatinine, and 43% had a cholesterol test, the lipogram test. So those are the kinds of things that we need to look at.
Irene, thank you so much for that. Just that last slide on diabetes and indicators. I just wanted to say that in the States, there's an organization called HEDIS, and yeah, HEDIS, and they, if you go onto their website, you can see how many sort of amputations or downstream costs have been saved by people having preventative measures and screening tests. So it's a huge topic and a very interesting topic.
It
Irene,
is, Heidi.
yeah, it really is.
It is a big thing.
Yes. Irene, thank you so much for that excellent presentation. It was great. You covered so much in such a short time. And thank you too for including this little slide on abbreviations. We know that this industry is full of abbreviations and acronyms, and it's important that trustees know what they are and what they stand for. And in all the previous modules that we've done so far, we've included a list of abbreviations that we've used in that module. So this is a common abbreviations that we've used today. And then just, I think, to say again, Irene, thank you so much for this. Thank you so much to everybody for joining us. There are now 4 trustee training modules on the HFA website. Please go and have a look at the others, and there are more to come. So watch the space. Thank you, and goodbye to everybody.
Thank you, Heidi. And also, just to let people know that they can reach out to us. We have got our emails.
Please don't hesitate to reach out to either of us.
Thank you.